The broadcast is now starting. All attendees are in listen-only mode.
Thank you everyone for joining us for another Learning Lunch hosted by formatapproved.com. My name is Brian Johnson. I'm the Senior Director of Online Training and Education with Formed Training, and I'll be your moderator today. Today's Learning Lunch will cover what is a meaningful use audit. We are joined today by Jim Tate of EMR Advocate Incorporated. Jim is one of the top meaningful use audit experts in the country, and he has helped to guide both eligible professionals and hospitals through the audit process. An MU audit is one of those unpleasant developments we hope no one suffers, but if you do find yourself in that circumstance, you want Jim in your corner. Before we begin, please note that you can ask questions of our presenter at any time during today's session by entering them into the chat area during the presentation. In the second half of our session, we will address as many questions as time allows. If we do run out of time, answers to all submitted questions will be posted to our website and sent via email link later in the week. Also, please note that all registered attendees of today's session will receive an email with links to both the recorded and PDF versions of the event. As a final note before we begin, I just want to say that your moderator is recovering from a summer cold, so I'll try not to sneeze into the mic, but rest assured you're at no risk of contagion due to the internet. So I apologize in advance if I do happen to cough. All right, Jim, let's begin. First of all, can you provide...
Good afternoon.
Oh, yes. Thank you for joining us.
Yeah, glad to be here.
All right, so to begin, provide some background for us on meaningful use audits.
Well, we knew they'd be coming one day. When the high-tech R legislation was signed into law in early 2009, that brought into fruition the EHR incentives, there was a plan that there would be audits. And so it took a couple of years for the whole audit process to kick in. But essentially, as our listeners probably know very well, there are two EHR incentive programs, the Medicare and the Medicaid EHR incentive programs. And there is one group, Figliosi and Company, that has the federal contract to do the Medicare audits. And the Medicaid audit, since Medicaid is run on a state-by-state basis, each state is responsible for doing their own audits. Now, for hospitals, quite a few of the hospitals are dually eligible, Medicare and Medicaid, and those audits are also handled under the Medicaid auditor, Figliosi and Company. One thing that's a little bit of interest is, as I said earlier, we were waiting to see when those first audits would appear. And I first started hearing about the first few ones maybe last fall. And over the last couple of months, especially as audits are now occurring not only after a incentive payment is received, but actually prepayment audits. As soon as you attest, you may be audited within just a few weeks. And almost every EHR vendor I've spoken with and quite a few providers I've spoken with have heard of somebody who's being audited. So it's here, and we're going to hear a lot about it over the next few years.
All right, so what are some common ways that people can avoid becoming an obvious target of a meaningful use audit?
Well, great question. There's definitely some ways that draw attention. Such things as during the audit process, when meaningful use is attested, and you go to the CMS web-based forms and enter numerators, denominators that make up the meaningful use objectives, it's mathematically impossible for every denominator to be the exact same number, just simply because some of the meaningful use measures you're attesting to have to do with number of unique patients. Other ones have to do with number of encounters. So there's just no way that all denominators can be the same. But some providers go in. I've spoken with a few who've done it, and I've heard some reports secondhand, and just put down the same numbers for every one of the meaningful use denominators. That's just mathematically impossible. So I would imagine that type of spurious information that going into a system would most definitely trigger an audit. Or if somebody scored 100% on every meaningful use objective, that in itself is probably pretty unlikely. So I think it would be pretty easy for whoever's drawn up a list of those hospitals or eligible professionals to be audited to just do some database queries against the numbers that are being reported. One thing that's problematic is that, especially back in 2011, when the incentive program first kicked off, there was a real knowledge gap, still a lot of a knowledge gap, but it was very easy to attest, go online and attest, and essentially no documentation was required just to attest and receive an incentive. And it was so easy that I think quite a few providers incorrectly made assumptions. I'll give you one example, Brian. I had a call yesterday from a provider who had attested in 2011 and was going through an audit right now, and he had the information, incorrect information, that the only patients he had to put in his EHR were Medicare patients, and that's just not the case. 80% of all your unique patients that you're seeing have got to go in that EHR. He didn't understand that. So wasn't much I could do to help him. It was just a knowledge gap early on. I think there continue to be some knowledge gaps that kind of generate some of those audits. Something else I'll give you, kind of surprisingly enough, the federal government has published data that shows who has attested for meaningful use, and they also report in a giant spreadsheet which certified EHR they attested that they use to achieve meaningful use. And vendors go in there and take a look at that list and make sure everybody who's claiming they use their EHR is actually customers of theirs. If they're not, some have called me and told me they placed a phone call to the EHR incentive information hotline and report. So you definitely want to be very careful about doing anything that's really way off the mark like that.
So what are the most misunderstood documentation requirements for attestation?
Yeah, that's a great question. From everything that I've seen, the one that is misunderstood by providers, by many hospitals, and by many vendors is the requirement to do a security risk analysis. There are a lot of myths around this. Many providers think that if they install a certified EHR that has been certified for security, that they meet that requirement. They think it's really totally up to the vendor to be responsible for the security issues, or they may have put together a simple checklist and think that that's going to be sufficient for the for risk analysis, but that's just not true. If you are audited, the auditors, one of the first things they're going to ask for is that security risk analysis assessment and their related documentation. They want to see that you've looked at your workflows, your hardware, your software, and nobody ever scores 100% on security risk analysis, but they want to make sure that the major gaps in that protection of electronic health information have been identified, and there's some mitigation plan that has been put together to close those gaps. So I really would think that at least on not hospitals but eligible professionals, I would really think it's probably over 50% do not have documentation for that security risk analysis.
And so folks understand that.
And if you don't have, yeah.
No, I'm sorry. You go ahead.
Well, I'm sorry, and it is the way the EHR incentive program is configured. It's all or nothing. So if you are not able to provide documentation in one area, all the incentives go back. So it's not just a partial, yeah.
I was just going to add that there's a lot of different parts to that risk analysis, everything from ensuring that you have policies in place to training to vulnerability testing. It's not just something you check off in an EHR, as you were saying, and then you're done. There's a lot of different parts to it.
You know, it is. That's one of the giant areas of misunderstanding. Another one that had to do with attestation took place for hospitals as well as professionals in 2011, 2012 was the core meaningful use requirement to do at least one test of exchanging key clinical information. And it took back in 2011 and even 2012 and in some isolated areas today in 2013, there may not be a lot of clarification and guidance, but it definitely wasn't back in 2011. And so this exchange of key clinical information was very much misunderstood by almost everybody. But during attestation, it was just a yes or no question. If you said yes, well, that's great. And if you got audited, they'd say, we want to see proof of that. We want to see an email coming back where somebody said they received it, or from a health information exchange, some type of screenshot or documentation that there was a test of that. Interestingly enough, this particular measure is so confusing, it caused so much problem that for 2013 it's been removed, and during attestation for this year, for 2013, they don't even, that's not even a meaningful use measure. So I think a lot of the, especially the 2011 audits, when they start looking at that documentation, people are base a lot of their documentation or lack of it really on misunderstanding. Now, but it's not a knowledge gap. I think somewhere out there, there were people who just thought it would be a very easy way to get money, because essentially there is a very little check and balance early on. And by that fact would be if you had an NPI number and you were able to register, you could go in there and attest and put in any numbers and claim any EHR you wanted to. And usually within 6 weeks you get a check, maybe up to $18,000 if you're a Medicare provider. So there was a lot of pushback from the government entities taking a look at oversight, and that's one of the reasons some of these prepayment audits have started coming to the services. I believe they probably started in January of this year. And as recently as 6 or 9 months ago, I heard some presentations by CMS on some of these issues, and they said the Department of Justice was not really interested in any of anything that turned up, because they figured it was mainly just a knowledge gap. But in the last couple of weeks, I've read some interviews that said that in some of these audits, they turned information over to the FBI to actually do some investigation. So you get a large practice out there, multiple sites, 30, 40, 50, 60 providers. They can get into a lot of money. And if they start digging in one of those, there really could be some reasons for some more than just knowledge gap.
So generally, it would be a civil matter if it's just a knowledge gap, but if there is evidence of fraud, then it becomes a criminal matter. Is that correct?
You know, you know, it's what is, you know, that's up to those investigative bodies to determine if it really is a criminal matter.
Sure.
I think the auditors and this whole process, the goal is health information technology adoption and rollout. And so if you start taking a lot of providers and penalizing them very heavily because they didn't really understand what was going on, it's going to have a chilling effect. So I think they have to walk a very delicate balance. And for those providers who are making a good faith effort and are hitting the numbers and understand what they're doing, I think it's part of it. There's really nothing to be concerned about at all.
All right, before we go on, we've already got some questions, which is fantastic. We're going to save those for the end, but I just want to remind our attendees that you can go ahead and ask your questions now, and we'll ask them of our expert at the end of the session. So let's continue. Who typically does get audited then?
Well, it's kind of fascinating. They've actually come up with some some numbers of how many they think are going to be audited. CMS, I've seen some quotes in the last month or so say they intend to audit 5% of participants. Other places I've seen up to 10%. So somewhere between 5 and 10% of participants. I don't know exactly how that that actually leads me to other questions. Since somebody might be attesting 3, 4, 5, or in case of Medicaid, 6 years, whether that increases your chance, whether 5 or 10% of all attestations, or it's just going to be individual, unique providers going to be audited. But as of March of this year, over 160,000 unique eligible professionals have received Medicare incentives. And so 10% of that is 16,000. 5% is 8,000. So far, there's a gigantic number of that either have been or in the process or will be audited. So we're going to hear more and more about it. And just how the meaningful use program over a number of years has morphed and shifted somewhat based on clarification and guidance. I've also found that the audit process has changed somewhat. Very early on, a lot of the audits that took place, I'm sure the auditors are going to CMS to help get clarification and guidance on some of these specific meaningful use measures. And even such things as some of these measures are very difficult to audit. I'll give an example. None of the percentage-based ones, but some of the yes-no meaningful use measures, such as did you have clinical decision support enabled? Did you have drug-to-drug and drug-to-allergy interactions enabled for the entire reportable period? Very, very difficult for a true audit to be done on that. There's CMS guidance that you could do screenshots showing some of these things that's dated, or depending on how your EHR is configured, maybe get a letter on the letterhead of your EHR vendor. But that's not true auditing of documentation. And so it'll be interesting to see if those will continue to be audited. But I think no doubt security risk analysis, as far as the yes/no ones, they're always going to be asking for that information. That's just critical. If we're going to have electronic health information, it's got to be secure. No doubt about that.
So who then performs the audit, and how do you get notified if you're going to be audited?
Yeah, that's a great question. Most of the experience that I've had has been with the Medicare auditors, Figliosi and Company. It's an auditing firm based in, I believe, New Jersey, and they were awarded the Medicare and Medicare/Medicaid contract. Of course, the states themselves do the pure Medicaid audits. And the first notification is an email that you receive. And the email comes to the email contact that was used during attestation, registration, attestation, and all that contact information goes in. And it is a letter with from a CMS email address, but it's from Figliosi and Company, and they essentially say you've been selected for an audit. We'd like to see we'd like you to provide us all the information you used during your attestation in 2011 or 2012 or whatever year that they are performing the audit for. And they want you to upload to their secure portal or send in some other secure fashion your documentation. And really what they're looking for is the report that came out of your certified EHR, some type of meaningful use report that covers a certain reportable period, numerators, denominators, report coming out that show clinical quality measures, security risk analysis, and really any documentation that you do have legal access or license or purchase that EHR. So they're going to want that documentation. And every one of those letters I've seen, you're given 10 business days. Now, people ask me all the time, well, what if the person whose email was given no longer works there? and the email bounces. Well, that doesn't work, because if the auditors don't hear from you, they find other ways to get in contact with you. So just ignoring the email certainly doesn't do anything beneficial for you at all. So it kind of gets off to a bad foot when they try and track you down.
Well, and then you'd have less time to get your stuff together.
Well, you know, that's exactly right. And sometimes it can be even a little more complicated. If somebody perhaps attested in 2011 and maybe they'd used an EHR and didn't like it and switched to another one, maybe they're having to actually, they aggregated their data from 2 EHR systems to report. So sometimes it can take a little while to do this. Of course, the best practice is to have a folder for every year you attest and have all your documentation in there. Often that's not done, but that's certainly, you know, a great way to do it, where you just reach out, grab it, and forward that information to the auditors. The next step that is kind of interesting about this is if there's any confusion about your documentation, or they have any questions about it, or if it doesn't meet their expectations, they're going to ask for more information. Frequently, you could have run a meaningful use report in 2011 and got some numbers and reported them successfully and attested those. And then after that period of time, there could be reasons why those records were entered again, and some additional documentation was redone. And then if you go back in now and ran that report for that same period back in 2011, you might have slightly different numbers. Still might be meeting meaningful use both times, but your numbers would be a little bit different. So if that occurs, they may ask you, for an explanation of that, and there are some legitimate explanations.
So what are the steps then in the audit process?
Sure. Well, kind of talk about the first 3 of them there. First is the notification. Again, we're on the Medicaid side. I'm sure it's all over. You know, we've got numerous states. Everyone has a different process, but the majority of the audits are going to be on the Medicare side. There's going to be a letter received. There's going to be a request for documentation. When that documentation goes in, there's going to be a response and request, and it may be a request for explanation, clarification, some guidance about some of the information you provided, or it could just be a very quick response saying some of these numbers you've reported in your documentation are not meaningful use, but you did when you attested, so there could be a question for to give a little more clarification. At some point down the road, there's going to be a letter of final determination. And so after going back and forth, if it's necessary to go back and forth a few times, provide additional documentation, those auditors are going to give that final determination, either saying you're good to go, or you failed to achieve and possibly failed to document that you achieved meaningful use. And everyone I've seen where somebody failed an audit, it was because the auditors are very specific to tell you what measure you did not successfully achieve meaningful use. That's the final determination. But with that letter of final determination, if it's not a good outcome, is the information that you're going to get a demand letter to recoup all the incentives you tested for that year, but also information will be in that recoupment letter outlining your appeal process. There is an appeal process, and so you can appeal, possibly provide additional documentation, or I think it could be very easy that somebody could have handled the audit process for a hospital provider, maybe didn't understand all the issues, didn't really understand what the auditors needed, and they failed the audit. But you've got that chance of an appeal, maybe bring some other resources or some experts on board, and make sure you don't fail that appeal. Especially for hospitals, there's a lot of money on the table with these incentives. A lot of small hospitals in 2011, 20, 30, 40 bed hospitals, just on the Medicare incentives received over $1 million. And so here we are 2 years later. If they suddenly fail an audit and don't get it reversed under appeal, that's $1 million. And for a small hospital, that seems fairly catastrophic to me. So it's really just dire consequences, that kind of money with a small hospital.
So you've talked already some about documentation, and it seems like that's critical. What sort of documentation does someone need to be able to present during an audit?
Sure, and this is documentation which, under the best of circumstances, you're going to have on the in a drawer or sitting on a shelf somewhere. We're going to have electronic or paper documentation that supports the attestation. This is the meaningful use incentives, meaningful use reports that come out of your certified EHR. We've got to have that. We've got to have also any documentation for the, as I mentioned, the yes/no measures. Was clinical decision support enabled for the entire time? We have to have proof of ownership of certified EHR technology. In that first letter from the auditors, they're going to list documentation they want. That's going to be one of them, proof of ownership of certified EHR technology. Then, of course, that proof of security risk audit, risk analysis, and that needs to be dated. If I know a lot of providers, not hospitals, but eligible professionals, really received a lot of help from the regional extension centers across the United States. And those regional extension centers were focused on taking paper practices to electronic certified EHR, and then helping them achieve meaningful use and apply for those incentives. And part of that process is making sure that all documentation that's used during attestation is generated and is available and is stored safely. Because you don't want to have to go back 2 or 3 years and trying to recreate things. You could have different staff members. It's hard to remember that far back. So it really needs to be in place during attestation and then saved.
Before we continue, I just want to remind our attendees, because we've had several questions about this, that we will be sending out a follow-up email that will include both the slides and a video version of this event. So don't worry about that. All right, let's continue. So what happens then if a provider fails the audit? And then how does the appeals process work if there's any chance for an appeal?
Sure, yeah, and it definitely is. Let me touch on one more thing before we move on about some of the documentation that might be required. Definitely documentation on the clinical quality measures, because everybody has to report those clinical quality measures. And for some providers, especially specialists, dentists, radiologists, oncologists, they were able during attestation to exclude some of the meaningful use core required measures. But if those ones that they were able to exclude because they were outside their scope of practice, possibly documentation could be requested as to why you claimed a particular exclusion. So really, they say that every audit is the same, but that's true in one respect. But in another way, depending on the type of practice you have and whether you've claimed a certain number of certain specific exclusions, documentation may be required around those exclusions. No doubt about that. So if you have a bad outcome of the audit, and I've actually got one of those letters in front of me right now. I'll just quote from it. Your facility did not meet the meaningful use criteria. The incentive payment will be recouped. You will receive a demand for your total Medicare EHR incentive payment shortly from the EHR High-Tech Incentive Payment Center. The demand letter will include all information regarding the repayment process and will also include your appeal rights. And so the fact that you might have to appeal because you failed an audit tells me that you didn't have what it takes, you really didn't meet meaningful use, or else whoever was handling the appeal process on your side, the audit process on your side, really didn't understand what the auditors were looking for. Maybe they missed deadlines. There was just poor communication. And maybe you actually could have provided documentation, but were not able to, just because on the provider side there was a very poor process to meet that auditor and really know what their expectations are. So there really are some best practices for an audit. Let me mention a few of those before we go on. You've got to have someone in charge. If that letter comes in, that email comes in and says you're being audited, then there needs to be somebody in that practice who's going to be responsible for responding, for acquiring the necessary documentation, for getting the information they need. One of the saddest things I've experienced with this whole process about a month ago, I got a call one night from a new practice manager with 3 or 4 providers, and it was her first day of work, and she'd just been given a deadline for an audit that they'd been working back and forth for 2 or 3 months, and the deadline for the final determination was the next day, her second day of work. She didn't know anything about the incentive program. She didn't know anything about the audit program, and it was essentially just put on her. And so there's got to be somebody in charge. Maybe they're not the expert, but at least they're in charge, and they can reach out to a lot of different resources on the internet, regional extension centers, contact directly the auditor. That's a great practice. If you have any doubt about anything, those auditors, if your job is easier, their job is easier. So you can reach out to them by email, asking for more time, asking for a phone call to clarify exactly what documentation they're looking for, what might meet their needs. So that close contact with the auditor, not trying to shy away. You really have to embrace these audits. Got to watch the deadlines. The initial ones, all the ones I've seen, is 10 business days. They want some information back. If all the information is stored off-site, or if it's coming from several different EHRs and has to be aggregated, whatever the reason is, if it's going to be difficult to do it in 10 days, be right up front with the auditor and explain everything. That's a critical thing. Another best practice, you've got to look to your vendor for support. Some of the documentation you essentially are not going to have. There are hundreds and hundreds of EHR vendors out there, and some of the documentation that would meet some of the yes-no type criteria, clinical decision support being enabled the entire time, things like that. It may be possible to do a screenshot in your system, but you may have an EHR where that is hard-coded and is always enabled. You're going to need a letter from the EHR vendor. So the first thing I would do if I got an audit letter outside the practice is contact my vendor. I would think that any vendor of any size has had clients and users who have gone through numerous audits and has a lot of experience and has already been in the process of supporting these different auditing processes that are going on. So you got to look at the vendor, notify them very early on. I recently had a case audit. I was helping a hospital, and some of the in hospitals, the meaningful use criteria or calculations are a little bit more complicated. Some of the meaningful use measures, you can count patients who come to the emergency department in a couple of different ways. And so it was confusing back in 2011 how that could all take place. Vendors were confused. So frequently vendors were generating numbers on those meaningful use dashboards that in hindsight are not accurate. And CMS has said that the professionals, eligible professionals, eligible hospitals, their responsibility is to attest to what comes out of that certified EHR. That certified EHR is giving you erroneous data. That's not the provider's fault. So you shouldn't be blamed for a vendor not really having enough information to do the algorithms correctly. And last best practice I'd say is seek counsel if needed. And this will, of course, include vendors, regional extension centers, other people you know been through the audit process, information that Format Approved is put up, or a lot of different resources that are available. You want to be fully engaged through the audit process. If you're not, there's a risk that you get a bad determination and then go to appeal. And I'm working with a couple of hospitals right now, and they contacted me after they had failed the audit, and they were at the appeal level. And that's always more difficult because you've already got one strike against you. So hopefully.
All right, well, that concludes our main presentation. Before we get to the questions, is there anything you'd like to add, Jim?
Sure. I'd say the kind of going back to a couple of best practices, though, critical to have somebody in charge, critical to watch those deadlines, and critical to establish contact with whoever your auditor is. I've talked with a lot of auditors directly and in consultation with hospitals and professionals who are being audited. The auditors are human. They're doing a good job, but we have to help them with documentation they need, and it does not need to be an adversarial process at all. If it gets to that, then I think it's going to be much more difficult to have a successful outcome. I think we'll see more audits going forward, especially with these prepayment audits. We're going to see more and more of those, and I've had a number of providers call me who sent in their attestation, submitted it. Within a couple of weeks, they received a prepayment audit, and they just withdrew their attestation. They didn't want to go through the appeal. So, through the audit. So, if you have attested, haven't been audited, and you think your attestation is incorrect, there's an actual document you can go fill out and file, to correct your attestation information or to withdraw an attestation. So just don't be like an ostrich hiding your head in the sand hoping it'll all go away. Just really have to take it head on. So
I think that's a theme throughout all of the comments you've made. Hiding from the audit is not going to do you any good.
No, exactly.
All right, well, let's begin with our first question. Here we go. Are the auditors remotely connecting to the EMR and pulling the reports and the numbers on sample objectives, or are they coming on site or simply asking for more detailed info?
I've never heard of auditors coming on site, and I have never heard of them connecting to your EHR and pulling reports. Everyone that I've been aware of, every audit, has been a desktop audit. They request information, they request clarification, they request more information. It's been that way totally. They're incredibly busy. You can imagine if they're doing probably a number of thousands of audits right now ongoing, how busy they are. So I've seen no instance whatsoever, anything on site. Last year there were some kind of the first round of, I believe, 150 HIPAA audits where they went on site to really dig deep down into what practices were doing. And so sometimes people say, well, I heard that they're coming on site for audits, but those are not the EHR incentive audits, and I've yet to hear of one. So all just documentation being provided.
All right. Here's an interesting one. If you were required to pay back the money received, you received the money and then you got audited and you had to pay it back, can you reapply for stage one?
Let's see. I don't know exactly the answer to that. I think you could for the next year, but you can't do, no matter when somebody starts the Medicare EHR incentive program, they can always do 2 years at stage one. So even if they start in 2014, they do 2014, 2015 stage one. I don't think you could do stage one, be successful, be audited and not do stage 1 second year because you didn't pass the audit, and then do for a third year be able to do stage 1 again. I don't think you can jump ahead like that.
All right.
To the best of my knowledge, what I've seen so far. That's a good question. Yeah.
So here's a question about, this is a Medicaid question. So the difference here between Medicaid and Medicare is that Medicaid is administered by the states. So there's a little bit more complexity in terms of there's varying rules about the states. So this is a question about Tennessee. The question is, even though CMS is not requiring the electronic exchange of information for 2013, I have found that for Medicaid for our state of Tennessee, they are asking for this. Are there other states that are requiring this?
Well, it's fascinating. The whole Medicaid incentive program is really interesting because under Medicare, your first year you have to do whatever that first year is, 90 days of meaningful use of certified technology. The first year in Medicaid, there's no requirement to achieve meaningful use. The requirement is that you have acquired, implemented, or upgraded. And so most states, which have their online Medicaid EHR incentive, and you go in and apply for your first year, you don't even get to a screen for meaningful use. You just have to claim and be ready to document that you've acquired, meaning purchased, implemented, or upgraded. There's no requirement to even be using that first year. And immediately you're eligible for the incentives. And so, but this question sounds like for that in Tennessee, the exchange of key clinical information is still being required. Now, it was for Medicare in 2011 or 2012, but it's not for 2013. And I don't know if any state is still requiring that for 2013. And the reason I say that is because if somebody, well, let's say, and something else that's a little bit different about the Medicaid program is first year you don't have to be a meaningful user. Second year you only have to do 90 days. And so I'm not sure that person who's writing that question, what year of attestation was that required? It would have been 2012, but it's not required for 2013, and I don't believe it is anywhere, any state.
And I can't think of it off the top of my head, but there's web resources with CMS that go through the requirements by state. Isn't that correct? That's information people can find.
Well, it is, and CMS has said that that states could require a higher level of meaningful use for Medicaid. They couldn't do less than what the Medicare requirements are. And so I don't know about Tennessee in particular, but I'll take a look at their website and see what they say. Sure will. It'd be interesting if they still require that.
Yeah, just to remind our attendees, we will be we'll be posting a link where you can get written answers to these questions, so we'll be able to follow up on some of this. So someone has asked about security risk analysis and how to get assistance with that, and I'll let you address that, but first of all, there's a lot of commercial services out there that provide risk analysis. So I think one of the things to keep in mind is, are you going with a group that's reputable, or are you going to get a good one? Because you mentioned before that early on, especially, people in the meaningful use process got some bad guidance, and people may have gotten bad guidance on HIPAA as well. So can you address that question?
Sure, and it may just been bad guidance or no guidance. A lot of the regional extension centers are providing that as a service, security risk analysis. There's a lot of commercial entities that are providing that. There's a big difference between a small single-site practice of 1 or 2 providers and a hospital or 4 locations and 20 radiologists. Much different levels of complexities. And so reason why I think it's very, very difficult for an individual who is not really trained in doing this to really understand it is just have an understanding of all the potential places there could be risks that need to be mitigated. Are you using uninterruptible power supplies? If somebody's accessing the EHR from home, is the Wi-Fi signal encrypted? So it's hardware, our backups being made, hardware, software, and even workflow within the practice. I hesitate to recommend anybody in particular, but there's some really good ones out there. It has to be done every year. You either do a new one, or you do one, or you review one. It's an ongoing practice. So if somebody's ever done one, to get an EHR, the security risk analysis that is referred to under meaningful use is a subset of HIPAA. It's the HIPAA component of protecting electronic health information. And so it has to be reviewed every year, and it's really a good thing. It sounds like a hassle to do, but it helps identify places where health information can be exposed, and could be. Everybody always says, well, what's the risk of health information getting out there? Well, the number one threat probably is identity theft, because there's all that information there that somebody could use, insurance, Social Security information, tons of identity theft information there. So if you have a small practice, I think it'd be possible to get one of these done. I've heard figures all over the place, but $1,500, $1,600 for a small practice. A really large practice that takes 2 or 3 days on site, numerous providers, 4 locations, that might be $6,000 or $7,000. And other people may say much different numbers. But you really want somebody to do this who knows what they're doing. There's no doubt about that.
And there's so many different pieces of it. I mean, everything from disposal of hardware to, the physical safeguards require locks on things, and it's just a lot to keep track of.
It's exactly right. Many copiers may keep digital images of everything they've ever copied.
Sure.
So, right, it's things you wouldn't think about unless you thought about it every day, and you're really an expert in doing these and looking for where the potential gaps are. So and very important. And
I was just going to say, apart from meaningful use, OCR, the Office for Civil Rights and HHS, they're authorized to levy fines of up to $1.5 million. That's civil fines for HIPAA violations. So it's definitely serious business.
Right, gigantic fines, and it doesn't even have to be willful. I know there's some giant fines against the cardiology practice in the West, maybe in the last year, because they had a patient portal that had a calendar on it and showed patients' appointments. Well, I don't know if they flipped the wrong switch and had that activated or what it was, but they had a gigantic fine against them for doing that. So we've gone to an area of real enforcement around protecting health information. No doubt about that.
Well, this is a related question, and I'm not sure I completely understand it, but let's see if we can figure it out. It says, discussion about penalties above and beyond returning the money and how that extends to the business associate if involved in bringing a practice to attestation. So I suppose what they're asking is if the business associate guided you through meaningful use attestation, would they be liable? Maybe you can address that to the extent we can.
Yeah, that's a great question. Or even more succinct would be if your EHR vendor gave you bad advice and said you didn't need a security risk analysis because they were certified for security, and that's just plain wrong. But you attested, and then years later you got audited. They want a security risk analysis, and your answer is, well, my vendor said I didn't need one. Well, as far as the government goes, the individual who claimed meaningful use and attested is the one they want the money back from. Now, a side issue is whether you can claim some damages and or get involved in litigation with a EHR vendor or consultant who you feel didn't give you the right advice, something like that. But the government is going to get it from the person who attested and who received the incentive. You know,
So
the
there's no passing of the buck there, but you might pursue civil litigation on the side, but the government doesn't really care about that.
Right, that's exactly right. Yeah, that's true.
We have some more questions about risk analysis, but first let's address another question that's outside of that realm. And this question, and maybe, I don't know if this can be answered or not, but this person's interested if you know the percentage of small practices that are being audited. Is there a split on that, or what can you tell us about that?
You know, I don't know anything specific about that, just some anecdotal information. Every time somebody calls me and they're being audited, I ask them how large the practice is and is anybody else being audited. I got a call from a chiropractor last week. There's a prepayment audit that went on, and two other chiropractic partners are also being audited. But that was a wave of prepayment audits that started to occur. But in other practices, it'll only be one person. I always ask, you know, maybe out of 7 or 8 professionals, I always ask vendors if they know of any of who's being audited, who are their users, because they usually find out pretty quickly. And it's pretty common for them to say, well, there's a large practice, but only one person is being audited in there. Now, one thing that might make me think that you could get quite a few audits in one practice would be if one individual who's the proxy to register and attest for everybody just misunderstands something. And I've heard a practice that 5 professionals in it, and the exact same numerators and denominators were attested to for every one of those providers. Obviously, couldn't be right. So very early in the process, the auditing that went on, they said they weren't even going for the low-hanging fruit. They were auditing the fruit that was lying on the ground. And that was when those providers that were claiming the same denominator for every meaningful use measure, which we talked about is really impossible. Another thing I don't know about is if you got audited this year and didn't have your security risk analysis, does that put you on the short list for them to go back and audit you for the year before when you probably didn't have one also? That'd be shooting fish in a barrel there. It'd be pretty easy. But I haven't heard anything specific about that yet.
All right, we have several questions about risk analysis. We don't have a lot of. It is.
Yeah.
It always is. We don't have a lot of time left, but we might have time for maybe 1 or 2 more questions. So this question is whether will the auditors want to see a checklist of hardware, software, and workflow? I guess it's a question about what is the level of detail they're going to want on that documentation for the risk analysis.
Yeah, and I don't speak for auditors because I'm sure it changes somewhat over time, but part of the security risk analysis is an inventory of the hardware. There's no doubt about that. And I think they want to see that there's, if you look at the CMS guidance on this, they say we can't tell you specifically how to do it, but it's going to have these components. They really want to see that there's been some type of thorough review, some gaps or some cracks in the system have been identified, and there's a mitigation plan. Now, and as long as, I think, of course it's got to be dated, as long as that is seen, and it is a real effort, and not something that was just copied and pasted off the internet, I think that meets the requirements, especially if you've got dates to do corrective actions, and when you do those corrective actions, you document that.
Well, this question dovetails nicely with what you just said. How much credit do you get from the auditors, and maybe it varies to some extent, but how much credit do you get for good faith efforts to fulfill those requirements of meaningful use, and to what extent will they work with you on that?
Yeah, work with you. Some of these items are just black and white. Either you did it or you didn't do it. If you didn't do, if you've been audited for 2011 and you didn't do an exchange of key clinical information, or you can't document you did it, then there's no way anybody can work with you. You didn't do it, and so your entire incentive is at risk. But such items, a meaningful use score measure for problem list. 80% of unique patients have to have something on the problem list. Well, if your numbers are verifiable, it shows 71%, you didn't achieve meaningful use. So they're not going to round it up to 80% for you. So I would not think it'd be any working with those kind of things.
Sure.
Yeah.
All right, well, we're nearly out of time, so I want to remind our attendees that we're going to assemble all of the questions, any that we didn't get to, and post the answers on our site with links delivered via email later in the week. So look for those answers to your questions if we didn't get to them today.
Yeah.
I want to thank you, Jim, for joining us for today's Learning Lunch. I thought it was very informative.
Well, great. And if anybody wants to reach out to me directly, I think you've got my contact information on the PowerPoint. If not, it's just Jim Tate, T-A-T-E, at emradvocate.com, and we're glad to answer anybody's questions that way also.
Sure, and you can learn more about EMR Advocate at www.emradvocate.com. I'd also like to thank all of our attendees for joining us today. Remember that all of our registered attendees will receive an email with links to both recorded and PDF versions of this session. We're pleased to announce that we have a new Meaningful Use course available at ForMed Approved. Visit formedaproved.com/education/courses_CMUP.html. I know that's a mouthful, but you can see it on your screen there, to register for ForMed Approved's new Meaningful Use course. We have been hard at work to bring you this course, which provides comprehensive training for both eligible professionals and eligible hospitals on both the Medicare and Medicaid incentive programs, including Stage 1 and Stage 2 of meaningful use, clinical quality measures, HIPAA considerations, and more. Again, visit the address on your screen there to learn more about the course or to register. You can also learn more about our other training programs at formedtraining.com. Our next Learning Lunch will air on June 5th and will cover the subject of security compliance using online resources to meet the HIPAA training and awareness requirements. So that dovetails nicely with what we were just talking about on the risk analysis side of things. HIPAA training is an annual requirement, so we'll learn more about that. We'll be posting our entire slate of June webinars later today on our homepage at formedaproved.com. We've got a button there, which you can see on your screen. That's on our homepage. You can click that to learn more and register for those events. Keep an eye on your email box on our homepage for other upcoming topics. And thank you again for joining us today. I want to thank Jim again. This was a very informative session, and I know we all learned a lot. Thank you.
Thank you. Appreciate talking to you. Have a good afternoon.
All right. We'll see you at our next Learning Lunch.